Good morning, everybody. It is Thursday, June 9th, 2022. Our topic today is anaphylaxis. Okay. Do you have notes? Do you need presentation?
I have some notes in the, they come up on the side. Not a big deal. We can't have them available.
It's like a vanilla batter with sprinkles in it.
Oh, we don't need subtitles. My bad. How did I do that?
It's so good for whatever reason. And it also has burritos. Well, you have to record tomorrow when you're working out.
Yeah.
You also have to have family. Okay, so you don't have to make it.
I don't want that. I don't want subtitles. Oh, here's subtitle settings.
Well, I don't either, but you know.
Maybe it's not on anymore.
Yeah.
Okay, so once you start, just don't click the subtitles like I did. Okay. Okay, everybody on Zoom, if you guys throw in the chat, can you guys see the presentation? Yes or no? And can you hear us? Yes. Okay. Awesome. This will go away again, always by like hiding. Here, now you can. Okay.
Start this or you guys start this? Okay, then we'll just do it.
Okay.
Thank you.
Of course.
Yeah, I won't.
Really good. My dad was dying, so. Dying.
Like,
We were laughing for at least 10 minutes. For a Kelly flashlight, but I'm like, I'm sorry.
Okay.
When I was little.
You guys care if I get started?
Yeah, okay, we'll go ahead and start.
All right. So today I'm going to be talking about anaphylaxis. And then I'm Alex. I know we've all like met throughout the last 2 weeks, but I'm one of the TA ones. Kind of rounding out the end of the year for everyone. I think there's only like one more person from our class who has to do the PACU rotation. Okay, so to start off, just going over the pathophysiology of kind of what causes an anaphylactic reaction. So anaphylaxis is basically an IgE mediated type 1 hypersensitivity. Sensitization basically happens with prior exposure to an antigen. And then this antigen causes production of IgE antibodies. And then upon re-exposure, the IgE antibodies basically cross-link with the Fc receptors on mast cells or basophils and cause degranulation of vasoactive mediators, such as histamines, leukotrienes, kinins, prostaglandins, and other chemotactic factors and tryptase. This is also independent of the dose of the exposure. So basically you will have a reaction regardless of how much you are exposed to essentially upon the second exposure. All right. And then I just wanted to go over kind of general presentation or certain things you can see with an anaphylactic reaction. They are highly variable in presentation. So you can see either a few things or you can see all of these things. It just kind of depends. So it basically involves a combination of pulmonary, cardiovascular, GI, and then dermal signs and symptoms. And this was this chart I found, and it kind of is more relevant to anesthetics, but it breaks it up into MAC and regional cases versus general anesthetics. So out in PACU, I guess you will potentially see all of these things. This is more kind of pertinent to us back in the OR, but and it kind of differentiates things that you might be able to see in MAC cases when your patients are awake and can kind of talk to you more versus things you may see as far as like signs under general anesthesia when they're not awake and can't tell you. But in PACU, we would be likely to see kind of all of these presentations. So respiratory wise, you'll see dyspnea, tight chests, and then as far as signs go, you can see like hypoxia, hear wheezing, see laryngeal edema or mouth swelling, and then they may end up with pulmonary edema, which if they were still intubated out here, you would see like increased peak pressures on the monitor, which would be indicative of decreased compliance of their lung tissue. And then cardiovascular wise, they may complain of dizziness, or you may see loss of consciousness even in the cases of like cardiovascular collapse. And then as far as signs go, hypotension is a big one. We'll see tachycardia, dysrhythmias, and then pulmonary hypertension. That would usually only be in the case if they had like a pulmonary artery catheter in or something like that. And then there's always a potential for cardiac arrest too. And then cutaneous things or dermal things include itching or rashes. You may see perioral edema and then periorbital edema, as well as flushing and hives. And then for renal things, kind of the biggest thing is decreased urine output, usually secondary to the hypotension and decreased cardiac output. And then GI wise, they may complain of nausea, they may vomit or have diarrhea. And then hematologically, we may encounter DIC, but we would probably have gotten testing and blood work at that point for or to suggest that. So you might not see that on initial presentation, but something to be mindful of. And then just going over causative agents, the most common types, basically associated with perioperative anaphylaxis, with muscle relaxants being our most highly involved. So Sux, rocuronium are our most commonly used ones here. And then latex rubbers, and those are involved in a lot of different products that we use here, gloves, tourniquets, Foleys. And then antibiotics, followed by hypnotics, colloids, opioids, and then a plethora of other substances. So I guess actually going back to this, big thing to look out for here, I guess coming out into the PACU are more so like if someone's been given Sugamidex, or that's another highly indicated or a highly likely causative agent too that's not necessarily listed here. But sometimes we can get an anaphylactic reaction right after we give Sugamidex and walk out into the PACU, and then someone is like experiencing an anaphylactic reaction. All right, so as far as incidence goes, total incidence is kind of variably quoted, anywhere from 1 in 10,000 to 1 in 20,000 general anesthetics. But again, it's kind of difficult to discern how many of these are true anaphylactic reactions because there is such wide variability in presentation. And then kind of two of the common ones that we might see out here too, ROC and Sugamidex. And the incidence for ROC, super variable, quoted anywhere from 1 in 3,500 to 1 in 4,000, 4,500 anesthetics. And then Sugamidex is quoted anywhere around 1 in 35,000. This is becoming increasingly implicated as a cause because of our increased use in it for general anesthesia. And then something I wanted to make people aware of too is that as far as anaphylactic reactions go, they, in relation to neuromuscular blocking agents, they're actually more common in women, and that's largely due to the reaction of a tertiary or a quaternary ammonia group that are common in cosmetics and like personal products and over-the-counter cough medicines that can kind of cross-react with neuromuscular blocking agents too. Here's a picture of my parents' dog. There's like a timeline of her being like itty bitty to a lot bigger. She's so cute. She's a quarantine puppy for sure. She's super spoiled. Her name's Liesel. My parents wanted a German name for their German Shepherd. Yeah. So cute. Okay, going into risk factors, big things include females, mast cell disorders, multiple past surgeries due to the previous exposures, and then history of anaphylaxis, allergic drug reactions that they've had in the past, and then more so allergic conditions, asthma, eczema, hay fever, things like that. So I just wanted to go over two kind of the certain patterns you may encounter with anaphylaxis. And they're grouped into three big ones, and they are uniphasic, biphasic, and a protracted course, basically. So as far as a uniphasic anaphylaxis reaction goes, this is what we'll most commonly see. These account for about 80 to 94% of all episodes, and they usually peak within an hour of onset of symptoms and then either resolve spontaneously after treatment or in several hours. So probably the most common reactions we'd see out here in PACU, or if something happened in the OR and someone was brought to you after like stabilization, ideally this would be the course it would take. And then as far as biphasic reactions go, there's an initial reaction followed by this asymptomatic period of about an hour or more, and then a subsequent return of symptoms without any further exposure to that antigen. And then time periods between resolution of the first reaction and the second can range anywhere from 1 hour to 48 hours. So something to kind of be vigilant about, even if they've been treated for this in PACU, or I'm sorry, in the OR or something like that, that there can be a recurrence of symptoms once they come out to the PACU, if they do come out to the PACU. Sometimes, depending on the severity, people will be transported to ICUs and stuff too, but just to make you aware. And then as far as protracted anaphylaxis goes, it's basically a protracted or persistent anaphylactic reaction that lasts anywhere from hours to days without clear like resolution of symptoms. And then basically experts suggest that this will, for it to be considered a protracted anaphylaxis, it needs to last up to like 4 hours, apparently, or more. Okay, more pictures of dogs. I have so many pictures of dogs on my phone. These are just like people from residency. So this is actually Kat's dog when, I don't know if you guys have met Kat Krakowski, she's one of our ones too. This is her puppy like last year. It's one of my other friend's dogs from residency on the west side of the state. And this is Anders' puppy. So cute. Okay, anyways. So diving into treatment, we're going to talk about basically acute treatment, what should happen immediately after a reaction is identified, and then secondary treatments, and then post-event things that we may want to think about too. So as far as acute treatment goes, you know, upon finding someone and you're suspecting an anaphylactic reaction, you should immediately stop any medications that you may think are the offending agent. Or maybe things that were just recently started coming out from the OR, things like that, that may be running currently or that you've just given. Call for help, and then you should administer oxygen, usually through a face mask out here, 10 liters or as high as we can go, and then communicate with the surgical and anesthesia teams. And then you should also consider discontinuation of other agents that cause hypotension. So as far as like narcotics go, if they're on a PCA or have an epidural pump running, you know, stopping those, and then anything else basically that may cause low blood pressure. And then starting an IV fluid bolus would be another big thing to start out here. They may require 2 to 4 liters immediately to start compensating for the vasodilation and hypotension. Sorry, my voice is kind of going out. And then next, you would consider giving epinephrine, just to go over the mechanism of action a little bit. The alpha-1 supports blood pressure primarily, and then the beta-2 receptors cause bronchial smooth muscle relaxation. So we can start anywhere from giving 10 to 100 mic IV boluses for hypotension, and then increase as needed. We may consider starting an epinephrine infusion, and then if they, for some reason, do not have IV access, there's always an option to give epinephrine intramuscularly, and then repeating those doses until IV access is established. And then just talking about our ACLS dosing, that ranges from 0.1 to 1 milligrams. And we consider that in like cardiovascular collapse or a code situation. And then you may want to consider starting other pressors for support as far as vasopressin or norepi. And then we should consider treating bronchospasms or respiratory symptoms with albuterol. And then epinephrine also helps that too. whether it be IV or racemic. And then I just took a picture of like the epinephrine that we have, or that we're usually carrying around in the PACU too, just to show you the difference in dosing. So this is kind of our big epi, and it has a concentration of 1 mg per 10 ml, so 0.1 milligrams per milliliter. And then our quote baby epi, which is 100 mics per 10 milliliters or 10 mics per ml. So those are the big differences in concentration as far as those go. And then as far as secondary treatment goes, if they're having signs of, respiratory distress or collapse and severe angioedema, they can't protect their airways anymore, we consider intubation. And then we consider putting in more invasive lines like additional IVs, A lines, central lines, a Foley catheter if they don't already have one coming out of the OR. And then drugs to consider after they've been stabilized include H1 blockers and H2 blockers, and then steroids as well, mainly to decrease like airway swelling and prevent recurrent symptoms in the setting of a biphasic reaction. And I won't go through dosing or anything, but there's kind of standard anaphylaxis dosing if we were to use those. Okay, and then as far as post-event things to consider, we should consider sending labs. So to help delineate if this was like a true anaphylactic reaction, we should ideally send serum tryptase levels, and those peak about or over an hour after initial onset of symptoms. A normal range is anywhere from 1 to 11.4 nanograms per milliliter. So basically, acute elevation of serum tryptase indicates degranulation of mast cells, and they usually stay elevated for like 6 hours after the event. So ideally, you would send those. You can also send serum histamine, but they peak about a half an hour after the initial reaction, and they go back to like normal levels, I think, after around an hour or so. So sometimes it's not always possible to get histamine levels, so that's why we usually send a tryptase. And then tryptase usually returns to normal levels about 6 to 24 hours post-event. And then if it is elevated, it's important that they seek testing usually after their event, maybe like a couple weeks afterwards, to see if there is a difference in their tryptase levels or if they've returned to normal, because sometimes people can have naturally elevated tryptase levels. So it's important once they're back to baseline to kind of see if that's where their tryptase levels are, or if they truly did have a big elevation surrounding the event. And then we talked about biphasic reactions too, but it's important to continue monitoring them up to 24 hours after their event/recovery, and potentially keeping them intubated and sedated while they stabilize. And then again, referring them for postoperative allergic testing, not necessarily something we have to worry about here, but just knowing that that's something that should probably be considered after they leave the hospital too. There's a bunch of pictures of all of our like events over the last years, just fun things. They turned out really blurry. I don't know what happened here, but like Halloween party, tailgating, cider mill, picnics, stuff like that. A lot of familiar faces, Rob. Yeah. Okay. And then just to kind of finish up, if you're concerned about someone having an anaphylactic reaction, it's also important to consider other things that this may possibly be too, that may present in kind of similar ways, because again, these reactions can be super variable in presentation. So you might have a patient who has like all of these symptoms, or you may have someone who's just like super hypotensive and is maybe kind of like short of breath. So important things to kind of think about in your differential when we're seeing someone in PACU like this. So big things to consider are vasovagal reactions, seizures, CVAs, and then shock. I feel like big things that we more commonly see out here at least are vasovagal reactions, and then kind of, I guess, more shock pictures, whether it be hemorrhagic or septic shock. I think that one's kind of pretty hard to differentiate sometimes, is shock versus anaphylaxis, because we see a lot of the signs and symptomatology as far as those things go. We see big hemodynamic changes like hypotension, tachycardia, things like that. So again, just things to be mindful of. All right. Kind of it. This is Jace's dog. I'm sure you've all seen pictures of Penny during his time here. They got an ATV and they got her little goggles for the ATV. So that's all. Yeah, I know, right? Okay, short and sweet.
Anaphylaxis, my husband is having my dog is like, he's having allergic reaction.
Oh no! Aw.
Oh my gosh. Better go stat. I think I have steroids. I think in dogs though, they don't compromise their airway. That's what I was trying to have allergic reaction when it's swelling at the face, but not the airway for whatever reason. It was horrible. Yeah. I don't know. You got stung by a bee. Bumblebees are really, I don't know.
My gosh, my dog goes crazy over bees. Like it scares me every time because he snaps at them and like you are not gonna get stung. Did you bring me?
Yeah, the donut holes. You're welcome. Sheila made the brownies for Dan's last day.
No, no.
I could also have it.
Thank you. You just so random that I was like,
My husband just texted me and was like, hey, our dog is having a reaction. I know. He probably got stung by a bee. I don't know.
Yeah.
Shaking screen was stopped. Okay. Sorry, I can't see slides on Zoom. Oh, the puppy. Uh-oh. Could you guys, hopefully you guys could hear it. I think that's what happens when presenter view. But they can't always see the slides, but I'm sorry, you guys. Hopefully you guys could hear, and I'll send out the presentation to everybody.
Oh, I'm so sorry. I didn't even see
That's okay. I got everybody in attendance. So we'll go ahead and end this.